Just a little correction. It's the term used and defined by FDA. It's patient-reported outcomes. And in my presentation, I will have two parts. One, more basic and general why and how we should measure patient-reported outcomes, what are theoretical bases for this measurement. And then at the end of the presentation, I will give you a few examples from HIV. Please, if you have some questions, just raise your hand even during the presentation. So now we talk a lot about quality of life. Everybody says, yeah, our new treatment improves quality of life. Is it new? No, it's not new, but maybe 20, 30 years ago, quality of life was considered something as not very serious, like soft endpoint, and the studies were maybe of poor quality, and it was more like a fishing expedition for the data. Now, we have several societies working specifically on quality of life and patient-reported outcomes. And we were working with FDA since 2000. In 2004, FDA released guidelines. Released guidelines and set up very high standard how to measure quality of life and patient-reported outcomes in the clinical trials. And so now also firms, they can have claims which part of quality of life they improve with their treatment. And also Professor Chassani and some people wrote some reflection paper from European agency how to measure quality of life, but now we have also European Food Safety Agency, but also the European network of HTA agency that consider that health-related quality of life is one of the three most important endpoints to be measured in clinical trials. Which are the endpoints that are usually measured in clinical trials? Those that you know, usually it's biomarkers, clinician reported, like clinical examination, observer reported. But all those what we are going to talk today, it's patient-reported outcomes. So what are the patient-reported outcomes? This is any outcome that comes from the patient. So it's assessed by the patient, and it can go from a single item and simple concept like pain to multi-item tool, like sometimes they can be unidimensional, measuring just function or fatigue, but most of the time, if we talk about what is quality of life, it's multidimensional, assessing at least psychological, physical, and physical. So why should we measure the perception of the patient in clinical trials? It's because if we have a new treatment, maybe we say, okay, we have some new treatment, they will fit to everybody and patient will like it. No, we can't predict the impact of the treatment over the disease on quality of life. And so today we are really in the situation of the chronic disease. Therapeutic benefits are rarely curative, like was the case of hepatitis C. So we can cure it. It was really exceptional situation. But most of the time, we just will try to improve and restore quality of life. And now we have, in all this disease area, we start to have many good questionnaires validated to measure our outcomes. Another reason why we should measure quality of life from the patients, it's in general a weak correlation with other outcomes. And so this is, for example, from COPD, and you can see the correlation between the good condition in hospital with a nice nurse comparing to real life condition with the same level of physical effort. The correlation in this study was rather mean, 0.5, meaning that we are not measuring always the same thing in hospital at home, and what we want to know is the real patient's quality of life. Another reason why we should measure quality of life is discrepancies between patient and doctor perception. So you, as a good clinician, probably you always think, yeah, I know, I examine my patient, I know what these problems are. Well, we've done this comparison in several disease areas. There was always discrepancy. This example is from irritable bowel syndrome. And there was pain intensity evaluated by the patient here, and pain intensity estimated by general practitioners after seeing the patient. So ideally, we would have this line, the perfect correlation. However, the real life situation is like this. So when the patient pain goes to be more stronger, all this area we can see that clinicians, they really underestimate the pain of the patient. But sometimes it can be opposite. It depends on the representation of the doctor for the disease area. We compared the body of the patient in venous insufficiency and more severe disease, and the disease that doctors they thought they were more severe, they tend to overestimate the impact on the patient's life. And as I said already before, the impact on quality of life is not always foreseeable, and it's not systematically correlated with the severity of the disease. So here the example is, for example, quality of the life of the patient just after cardiac arrest. It's rather good. But if we look to the chronic low back pain, the quality of life is as impaired as patient with COPD with oxygen-dependent oxygen at home. This study can be criticized because it's like literature review with one generic questionnaire, so sometimes we can miss some disease-specific problems. However, you can see that you have to measure quality of life the best way you can, and you have to give as much methodological rigor as to other endpoints that you do. And sometimes you will have a criticism saying, well, it's subjective and it's not precise. Well, if you have your hard endpoints that we're watching all the time, like CD4, it's also just some proxy reflecting immunologic status of the patient. It's not like 100% the truth expressing their state of health. So this is the example defining in the situation from ERICA working group, and telling why and in which clinical trials the measuring of patient-reported outcome is useful. So it can be where the patient self-report is primary or sole indicator of quality of life, for example, in dermatological disease, in acne, and then we have a specific recommendation for this disease in European agency. Or there is no objective marker possible, migraine. You don't have other way. Or to measure that treatment prolonging survival in AIDS and cancer do not adversely affect patient's life due to morbidity, functional, psychological impairment, or side effect. So how to choose and how to look, if you look to the studies and you will do your study, how to choose best questionnaire, or if the firms will come presenting the results with their new treatment, how to consider is this result interesting and pertinent? Well, already it's important to look to the measures and the content of the measures that were looked for the study. So you must really check that all the relevant and important concepts are captured by the questionnaire. To develop a new questionnaire, it's long and rigorous, so it's good to use if you have already validated questionnaire. And you can be sure that one global question, how do you rate your quality of life, is not really working and cannot cover the complexity of patient's life. So this is an example. For example, if you have some study, you have to choose generic questionnaire, specific questionnaire. This is Irritable Bowel Syndrome questionnaire, and you will see in all the studies, all these generic SF36, SF12 questionnaire. Yeah, you have some physical and vital and social function for sure, but if you look to what the problem of the patient with irritable bowel syndrome is, they have also sleep impairment, they have to use sleeping pills, they have many food restrictions, they cannot go to the restaurant with the colleagues and friends. So maybe you would choose better, the questionnaire that is specific, FDDQL, that covers these dimensions: sleep, diet, abdominal discomfort. Else you cannot conclude. This generic questionnaire, you will say, okay, my quality of life is not so bad, but you will miss all the other parts. So what about development and validation of PRO tools? Before, you can see some experts, 2 professors and 1 patient representative sit in the evening, get good restaurant, and write down the patient questionnaires. So this is not possible anymore. However, it still can happen in some situation. Now you have really several guidelines how to validate the questionnaire, and you have to do some qualitative research to make the patient's interview, to raise relevant concept to put to your new questionnaire, and psychometric validation, and of course simple translation of the questionnaire by the clinician will probably not be enough, and you will need linguistic validation, at least like forward backward translation, and also what we call cognitive debriefing. So because if you ask the patient, do you understand the question, they will always say, yeah, I understand. But if you ask them, so what does it mean to you? And now you will discover really sometimes differences between cultures or concepts. So this is an example. This is example of lipodystrophy questionnaire that we validated long time ago. And you can see, I'm not going to the detail, that this questionnaire have to show several form of validity. So like discriminant validity, that the scores of questionnaire will impair when the health is impairing, some convergent validity, correlations with other tools, also construct validity. You have to show if your items and questions, they project on the model the same way as you were thinking when you were constructing the questionnaire based on the qualitative phase. When we started to validation Procol HIV several years ago, they were really, most of the questionnaire, they were really out of date. They were developed in the beginning of the HART era, and they were missing many important items, especially no one had a dimension about treatment impact or sleep, or and still until now we can see the studies coming up with all these questionnaires. They are not adapted and they do not respond to the research questions. So there is still an improvement on methodology on clinical trials to do. So how to choose an instrument? So for example, if you want to measure impact of fatigue, you should have either HIV questionnaire that has got fatigue dimension or some fatigue questionnaire. If you want to measure cognitive function, you have to take cognitive function questionnaire, or treatment satisfaction, or satisfaction with care. This is an example to show the place of quality of life and other PROs between other endpoints. This line would be like continuum or different endpoints that you can measure in a clinical trial. The slide looks a little bit complicated, but it's not so complicated as much. And so, for example, you can see that biological markers, viral load, and CD4, they have no correlation with quality of life related to the lap dystrophy. And then we ask the clinician to make a clinical exam of the patient and then to put down clinical signs. We see rather moderate, weak or moderate correlation between what patient perceive lipodystrophy on his body and the clinician. But still, I went to present. It was acid polylactic study that we make big cohort, and the doctors were saying, yeah, but you don't have a strong criteria like Dexasan to show lipodystrophy. I say it's better in this case if you want to, for example, inject for the face. The patient, the acid polylactic, it's better to ask the patient, but there is always somebody, they say, I see better than the patient if the patient's got lipodystrophy. No. So, and here there are different patient-reported outcomes that can be measured in lipodystrophy. For example, clinical sign and quality of life is not the same thing. And one global lipodystrophy satisfaction question, like globally are you satisfied with your body appearance, is correlated 0.658 with quality of life, but cannot cover all the multidimensional quality of life. Which are variables impacting on quality of life? So today, maybe we would say that it's more fatigue, central nervous system problems, treatment regimen burden, but there are also other, not only disease and treatment specific factors, but it's also gender in the woman. We will see across all disease area that quality of life is worse, and it can be also socioeconomic status. But be careful then, because we really want to measure health-related quality of life. Because if you will take, for example, questionnaire MOS HIV, you will measure environment, if the environment impacts quality of life. So this is an example of the study we made to validate a multi-dimensional questionnaire Procol HIV. We made it in 9 countries, and it was based on the qualitative and quantitative phase. And the objective is really to have the tool that would be adapted to all the cultural differences and also assessing treatment impact. And it was also published in 2014. I think it was maybe first electronic PRO published with the patient. And we could show that even our patient from sub-Saharan Africa having a low education could feel it on the hospital, on the screen with the help of the staff. So here are a few examples in quality of life regarding, or in the validation study regarding some dimension that was very important. For example, stigma. Here we have different dimensions in the circle all around. And stigma, you can see huge differences between country groups. For example, in Africa, patients really have to hide. But what was interesting with this questionnaire, and we could show and harmonize that the treatment impact, it was very close across all the countries groups. So I have to maybe I will speed it up a little bit. Just to show, again, when you look to the questionnaire and the studies, look to the length of the trials and look if how many questionnaires still from the global sample if you have many missing data, and timing and the criteria. All these things you should look the same way like when you look to the other data. And now at the end I will give just maybe a few examples. I don't have time. To my presentation that was more oriented to show the importance and basis of PROs. I don't have time to go to interpretation of the scores, but always think if somebody, the same way like when you look on the difference of viral load between the countries, they will tell you, oh, we are significant here, we are significant here. Think what is the difference between the arms clinically pertinent, and is the difference that we show something that is logical and expected. Here you have, so this was some results from Eclair, and we have a lot of satisfaction questionnaires. Satisfaction is not always the best way to measure patient perception, because already you will choose for your study you will choose the patient they want to go to this strategy. So it's not reflecting, and already the quality of life the same that the other pain points. Your patients will be always better than real life population. So you have to know this. And satisfaction, it's something also really global, and you have to be careful, because I saw, for example, in cabotegravir from some scores, they take out the pain out of the global satisfaction scores. Of course, now we have many new strategies to have light treatment. So we have like B therapy, we have injectable treatment, we have now validated, and you saw the results from French studies, 4 days a week. So it's important, all these strategies, also to show the benefit for the patients. This is example from Atlas. Yeah, you can see that there is no difference with generic questionnaire SL20 between mental component score, physical, between arms. Of course, there is no difference because this questionnaire is not able to show this difference. So what is the use to put this to the study? And this is another example. This is bictegravir versus Triumec, and patients' naive studies and switch studies. Again, I don't have time to go to the detail and to the interpretation. You have to look if the results are consistent, if they are at least present at different time points, and if they are related what was expected, and what is the really either size effect or difference of the score. This is another example of the study that we made, Optiprim, that was pentatherapy versus tritherapy with the patient in primo infection. And what was interesting also to see that quality of life improved from the baseline when patient discovered that quality of life almost in all dimensions, but in some dimension they still really stays, the scores are rather low, like stigma and health concern is rather low, but physical problems is not such a big problem, and body changes today. And what is interesting also is to look to the treatment impact, and we can see the difference between two arms, showing really that those patients that have pentatherapy, the impact on their lives was more important. We show also some differences on the and benefit for the patients that had only treatment 4 days a week, but maybe more in terms of patients' preferences, but I'm not going to present the results. So
your time is almost up.
Yeah, thank you. So the conclusion would be that patient-reported outcomes deserve as much methodological rigor than the other outcomes. Thank you.